Good afternoon, my name is Danny Gaskin and I'm a biomedical scientist by background and a patient blood management practitioner by day. My main interests lie in blood transfusion and in patient blood management, and I'm involved with the teaching and the leading of the non-medical authorisation of blood components training course at NHS Blood and Transplant. And I also sit on the UK and Ireland Blood Transfusion Network Education Working Group, whom are responsible for the guidelines on non-medical authorisation of blood components practice in the UK. It's a real pleasure to have been invited to come and speak today to members of the Southwest Non-Medical Prescribing Leads Forum. And I'd just like to say thank you to Andrew and to Sally for inviting me and for organising for me to be here today. Before I begin, I'd just like to highlight things that I'm not going to talk about today at this education event for non-medical prescribers, attended by lots of non-medical prescribers, and that is non-medical prescribing. And if you're sat there now thinking, well, Danny, why are you here? That would be a very fair question, and I hope over the next 30 minutes you'll be able to answer that question yourself, because one of the things I'd like to really get across today is the legal and the technical differences between the authorization of blood components and the prescribing of medicinal products and blood products. Because the terms blood components, blood products, blood prescribing and blood authorizing are often all used incorrectly and often inappropriately interchangeably too. We prescribe medicines, but you won't find red cells or platelets in the BNF, because blood is not a medicine. Blood is tissue. Blood is connective tissue. When we transfuse blood, we are, in a way, transplanting tissue from one human to another. And we don't prescribe tissue. We don't prescribe blood. For blood, we provide a written instruction for blood component transfusion. And to better understand that, let's have a look at what we're actually going to talk about over the next half an hour or so. Blood products, blood components, prescribing and authorizing. Danny, it all sounds the same to me. What's the difference and what does it matter? Well, we'll explore that today. What is NMA? What is non-medical authorization of blood components? We'll explore that practice and we'll explore how that practice has evolved over recent years. As I said, I sit on the UK and Ireland Blood Transfusion Network Education Working Group, who are responsible for publishing the guidelines on NMA, and we'll take a look at what those guidelines say. And finally, we'll have a think about how we can recognise our own scope of practice and our own professional accountability in relation to authorisation of blood components. But to introduce the topic, we need a bit of a history lesson. So all those years ago, back in 2005, an amendment to the Section 130 of the 1968 Medicines Act significantly impacted blood components. When I talk about blood components, by the way, I'm talking about red cells, I'm talking about platelets, I'm talking about FFP and cryoprecipitate and granulocytes. And this amendment to the Medicines Act, this regulatory shift, led to the exclusion of blood components from the Medicines Act. And instead, the blood safety and quality regulations of 2005 were introduced, placing blood components under these regulations instead. And this had significant legal implications, because this amendment effectively removed blood components from the legal definition of a medicinal product, meaning that blood components were and are no longer a medicine. And with this came an opportunity for change and an opportunity for the development of the practice of NMA. Because a lot like prescribing, traditionally the prescribing of blood had been a medical task. And this legal shift created an opportunity for other non-medical healthcare professionals to authorise blood components. There's a nice quote in a British Society of Haematology paper that summarises this really quite well. And that is that there are no legal barriers to any appropriately trained, competent, locally designated and approved, registered, regulated healthcare professional being able to authorise blood component administration. And note that this quote, and note that I keep referring to blood components specifically and not blood products. Blood safety and quality regulations defines blood components as a therapeutic constituent of blood. Again, remember, we're talking about red blood cells, we're talking about platelets, we're talking about plasma, so FFP and cryoprecipitate, we're talking about granulocytes. Blood products, on the other hand, well, they're medicinal products, they're still medicinal products. They're medicinal products derived from those constituents. When we talk about blood products, we're talking about human albumin, we're talking about anti-D, we're talking about factor VIII, we're talking about immunoglobulins, prothrombin complex concentrates, octoplast, octoplex. And these are still classed as medicinal products because they're still controlled under the Medicines Act. And I know this can be quite confusing, especially if you don't work with these items day in, day out like I do. We've all spent a career using the term blood products to describe all of these items. It's part of our vocabulary now. And still, even I see my hematologist, my hematology and my transfusion colleagues use all these terms interchangeably, but it's incorrect. An easy way to interpret this legislation, to remember this, although perhaps I wouldn't recommend using this one in court. If it comes in a squishy bag of liquid, it's usually a component. If it comes in a box or as a powder and requires reconstituting, it's usually a product. Although there is one common exception, and that's octoplast, which will come in a squishy bag full of fluid, but it's a solvent detergent treated pooled human plasma product. And because of that solvent detergent treatment part of the process, that is in fact a medicinal product. With all that in mind, and if we think about the evolving NHS, the evolving needs of our patients, the evolving workforce, higher demands on us, higher expectations of us, we all know how it is. It was recognised that senior nurses could potentially authorise blood transfusions. And so a collaboration between blood services in England and Scotland explored the feasibility of non-medical authorisation, involving key organisations such as the MHRA, the NMC, the Royal College of Nursing. And this work was supported by the UK Better Blood Transfusion Network, or as they were called at the time, they're now known as the UK Ireland Blood Transfusion Network. They supported this work. And this collaboration resulted in the publication of the framework for NMA, which was a publication by two nurses, Liz Perry and Jan Green, which really became quite a significant document for over a decade before its revision last year. And every time I present on this, I do like to make sure that those authors get that credit they deserve, because they were pioneers of this practice. And I certainly don't want to give the impression that I was involved in that work, or I should take credit for that work. I wasn't even qualified when Liz and Jan were writing up their paper. However, I did have a role in the 2022 revision as a member of that group. And last year, the revised framework was published, and we really built on the original work, and we stressed and emphasised in the revision that there are benefits, in fact, to various regulated healthcare professionals authorising blood beyond that of just medics and senior nurses. And this includes pharmacists, ODPs, paramedics, midwives, physiotherapists, and other healthcare professionals like yourselves here today. On the review group with me was some more colleagues from England. There were representatives from Scotland and Wales and Northern Ireland. And before publication, we undertook a large stakeholder exercise, really to ensure that we got strong consensus and support for these recommendations. As I said, we really tried to emphasise that any registered and regulated healthcare professionals who wish to expand their role to authorise blood component transfusions can do, so long as the appropriate governance is in place. And we'll talk about some of the governance that we make recommendations on over the next few slides. But it is important to keep in mind that non-medical authorisation of blood components and non-medical prescribing and the related training and governance, etc., are independent of one another. A non-medical prescribing qualification is not a prerequisite for non-medical authorisation of blood. And not being qualified and being a practicing non-medical prescriber does not mean you cannot become a non-medical authoriser. And conversely, being a non-medical authoriser does not mean you can just go and non-medically prescribe. It's a bit different for doctors, because as it stands, they do have the right upon qualification to partake in both activities, regardless of their experience, their expertise, and their understanding of blood transfusion. But what's crucial for us as non-medical healthcare professionals is that we must be registered with an appropriate regulator, such as the HCPC or the NMC or the General Pharmaceutical Council. And we must also ensure that non-medical authorization is permitted within our professional framework and regulations too. An interesting side note regarding physicians associates and anesthetic associates and other related roles, at least as of today, November 2023, these colleagues are not currently regulated. So they wouldn't be, not yet anyway, an appropriate candidate for this role development, at least while they remain unregulated. And I know there's ongoing talks about GMC regulation, but that's been delayed, I think, a couple of times now. It's been knocked back a couple of times. I think the next date that it's going to be reviewed is 2024. And we're certainly very interested in what the professional framework looks like once regulated by the GMC. In our recommendations, if you've not seen it, it's quite a comprehensive document. And what I've tried to do on this slide is to break that down into one slide and give you some key points. And I've broken that down into these 10 points here, and I'm just going to make my way through these. We need to ensure that a local non-medical authorization policy is in place before any healthcare professional can engage in NMA. Okay, and that policy must reflect the service's needs. It must also clearly outline the healthcare professional scope of practice, their responsibility and their accountability. And it must be regularly reviewed and updated, particularly in line with the national framework and any other key developments in blood transfusion. In terms of job description, this one is often overlooked because it seems like a minor detail, but it's so very important. Any colleague practicing NMA must have their job description amended appropriately, and that change must reflect their role scope. And that should continue to change as their practice develops. What's really important is that organisations maintain a register of approved non-medical authorisers as part of the risk assessment and governance process. And this register must be maintained, kept up to date, and should be accessible. When we consider staff who are not directly employed by the organisation, whether they're bank staff, agency, whether they work across multiple employers, they must ensure that they have professional indemnity arrangements through either their primary organisation or through some other means. In terms of education and training, healthcare professionals who undertake this role development must be supported in their practice by appropriate education and training, because there's a lot to get to know. There's a lot that they need to learn, as well as being compliant with the trust mandatory training requirements for blood transfusion. An NMA needs to have an understanding of anatomy and physiology of blood, of immunology, of anemia, of blood loss, either chronic or acute. They need to have clinical assessment knowledge and skills. They must be able to interpret blood results. They must be able to understand the different blood components, what they are, when they're indicated, the risks, the benefits, and any alternatives to them. They need to know about consent. They need to know about specific requirements. For example, does my patient have a condition such as Hodgkin lymphoma? That means they need to have irradiation treated cells. They need to know about some of the laboratory tests, which ones they need to order ahead of a transfusion. How do we ensure compatibility between the recipient and the donor of this blood? We also need to know some of the non-technical stuff, such as the law and regulatory requirements around, say, traceability and cold chain maintenance. There is a lot to learn, and details about the comprehensive minimum requirements of training and education are detailed in our framework. And then we'll need to consider competency assessment. We'd expect organisations and individuals to keep an evidence of competence and of annual reviews. We'd expect to see confirmation of ongoing competency assessment for authorising blood as part of an appraisal between the healthcare professional and the line manager. And We also define who is eligible, what are the requirements to undertake this role development? Well, we've already talked about being registered and regulated, but healthcare professionals must also have support from their line manager. They must have been approved by the clinical lead in the environment that they work and ultimately have the approval of their organisation. They must be able to provide evidence of knowledge, of skills and expertise in their relevant clinical specialty, wherever that is. And they must be able to demonstrate that same knowledge, skills, and expertise in managing patients who may require a transfusion. They must be able to demonstrate appropriate clinical assessment and decision-making skills, and also have a mentor approved by the relevant specialty clinical lead, and also approved by the hospital transfusion committee, or at least an equivalent local governance committee. And that mentor must work in the same specialty. And there must either be an experienced NMA, somebody who's already been on this journey, somebody who has already clocked up some experience, or they can be a senior doctor with suitable expertise and experience. Equally as important, they must have the capacity and the time to dedicate to supervising this healthcare professional until completion of training and competency. And beyond that, they must be able to commit to providing ongoing supervision and support too. On that supervision, following training and prior to becoming an independent authorizer, we expect that healthcare professionals will have a minimum of 3 months supervision period, or a locally agreed number of cases. And this is where it will vary locally, because depending on the progress that you make, depending on the frequency of transfusion in the environment that you work, if you work in the emergency department, you might see a transfusion every single day. If you work in a less acute setting, it may be that you see a transfusion once a week or once a month. And ultimately, the organisation must ensure that the clinical governance procedures and risk management strategies are appropriate and are in place to ensure compliance with the policy. So a quick legal pit stop, just to refresh our minds and remind us about the differences between the blood components and the blood products. Remember, in 2005, an amendment to the Section 130 of the 1968 Medicines Act resulted in blood components being excluded from the Medicines Act. And instead, they were controlled under the Blood Safety and Quality Regulations of 2005. And remember, the BSQR defines blood components as a therapeutic constituent of blood. So we're talking about red blood cells, we're talking about platelets, we're talking about fresh frozen plasma, cryoprecipitate, and granulocytes. So blood components excluded from the legal definition of medicinal products, and therefore cannot be prescribed, and instead they are authorized. On the other hand, blood products derived from whole blood or plasma, and we're talking about albumin, we're talking about immunoglobulins, we're talking about PCC and octoplex. And these are still classed as medicinal products because they're still controlled under the Medicines Act. Okay. So, Danny, it all sounds quite good. How can we introduce and manage NMA in my workplace? Well, NMA isn't new. We looked at the history just briefly just now. And the first framework was published, over almost 15 years ago now. On our course alone, we train around 150 healthcare professionals every single year, and the majority of them go on to become independent authorizers within their organisation. And often they report a real positive impact, not just on their own role development, but also on patient experience and the provision of service. So it may well be that NMA is already in place where you work. However, let's assume it's not. Let's assume that you're new here. And ultimately, the place to start is having your organisation formally accept the risk of non-medical registered and regulated healthcare professionals independently authorising blood components. And then following that, with implementing a policy and building a suitable and proportionate, robust governance system, ideally including all of the recommendations we've discussed today and all of the recommendations in the UK guidance. And then it's for each department, each clinical service, each community service, ward, unit, clinic, wherever you might work. to identify a service need within their department and then submit a proposal to the Hospital Transfusion Committee for consideration. And the Hospital Transfusion Committee will then consider a few things. Firstly, is there a service need? Well, the Hospital Transfusion Committee is made up of all the key transfusion folks in your trust or organisation. The highest users of blood, anaesthetists. We've got representation from the transfusion practitioner team, the emergency department, from the laboratory. And they will consider the clinical needs identified and the appropriateness of the proposal that you've submitted. And then they'll think about scope. If the HTC approves the NMA in that department, then they need to establish and detail which components and in which situations is NMA approved for. And this is about setting boundaries. We're thinking, oh, well, is NMA in this department going to cover just red cells? Is it going to cover platelets as well? Is it going to cover plasma and granulocytes? Is it only going to be approved in certain situations, such as sort of routine cases or with patients with sort of established and stable transfusion needs? Or actually, is it going to be for the more acute cases and the more complex cases? Well, that's for the local department and the Hospital Transfusion Committee to negotiate and agree. But it's very, very important that those, whatever is agreed, is documented, is detailed, and those boundaries are set. Establishing those boundaries is essential when we think about vicarious liability, for example. So that's a really important step. And equally important is for the HTC to determine the training programme and the competency assessment framework. We provide guidance on what that looks like. But essentially the execution of that is the responsibility of the Hospital Transfusion Committee. And as we discussed on the last slide, there is a lot to think about. There's a lot to get through. And finally, we discussed having a register and maintaining a register and keeping that register up to date and having that register accessible if the hospital, the trust is ever visited by the CQC or the MHRA, for example. So let's say you do go down this route. All the trust level requirements are in place. You've completed the training. You've completed your period of supervision. Your portfolio is looking good. It's complete. You're all signed off. You will then be able to authorize blood components, but exclusively within the specific area where you work and where you've been trained and within the scope of that training and that local policy. What I mean is it's essential to recognise that that competency is not automatically transferable elsewhere. So let's say that you have completed, you've gone through this whole process, and then you was to either move department to a new specialty or maybe even to a new trust. Well, at that point, you really need to consider whether or not the appropriate governance is in place for you to pick that practice back up. Is there an NMA policy in place in this department, in this trust? Has it been approved in this area? Is your job description still accurate? Has the scope of NMA, have those boundaries been decided and detailed? Do you have experience in this specialty yet if you've moved into a new one? Are you appropriately trained to authorise blood in this cohort of patients? You really need to have a think about that. That's really important. And of course, as with any role development, this is nothing new. You'll be responsible for participating in CPD and maintaining your own competence. And this includes day-to-day things like staying informed about developments in transfusion medicine, revisions to your local policies and procedures, adhering to national and even local guidelines, and maintaining your own competency is really your responsibility. Becoming a non-medical authoriser opens some doors. As authorisers, you will become an integral part of the transfusion process in your trust. And with that becomes opportunities to get involved with things. We encourage you to get involved with your Hospital Transfusion Committee and your Hospital Transfusion team. They have overarching responsibility for the training programme, the competency assessment framework that you will have gone through. You can influence that. You can influence practice. You'll be able to get involved in incident investigation, in policy and procedure writing. You'll be able to get involved in research and audit. You'll be able to get involved in promoting good practice and safety and the use of alternatives to transfusion. And perhaps you might even become a mentor for people coming through that same process that you've just been through. And for me as a transfusionist, that's really exciting stuff to be involved with. But there is some stuff that isn't so fun. Transfusion activity is regulated by the MHRA, and they regulate our compliance to the BSQR. And we know, as prescribers, that they are notoriously thorough. They have high expectations, and of course that's right. That's rightly so. Compliance with regulation is so important, and having a solid quality management system in place is just really, really important. And spending some time to get the governance right for NMA is really quite essential. Having that good, clear, updated, controlled policy and procedure in place, systems to manage hemovigilance, systems to manage traceability of those blood components, systems to manage cold chain compliance. All these things are really, really important because non-compliance isn't well tolerated and often come with some really quite serious sanctions. And they can range from fines to even imprisonment for the responsible person. And the transfusion department can also receive, the transfusion lab can also receive a closure order. And that impacts the entire hospital. Because if you don't have a transfusion service, if you don't have that transfusion laboratory, that potentially shuts down the emergency department. That potentially shuts down surgery, maternity, hematology, oncology. The knock-on effect is substantial. And the reason why I've included this in my talk today is because this emphasizes the importance of getting things right, both from an organizational and an individual governance standpoint, which essentially is how we keep patients safe. And this is why I'm presenting on this today. This is why our recommendations are so comprehensive. This is why NMA practice requires time, it requires investment, it requires appreciation. And this is why the training, the education, the competency and mentorship and supervision recommendations are really so comprehensive. And I'll finish with this slightly more pleasant message. Going all the way back to 1994 for this one, this nice quote by Hunt and Wainwright when they were writing about the expanding the role of the nurse. And it reads, legally, the concern is not whether a task or activity was carried out by a doctor, a nurse, a midwife, or any other practitioner. It is whether the patient received care to an expected standard. So long as the quality and the governance systems are in place and maintained, so long as the practitioners involved are educated, are trained, are competent, are supported and experienced, legally, technically, practically, there is no reason why experienced, registered and regulated healthcare professionals cannot go on to become non-medical authorisers. So thank you very much for your time. Thank you again to Sally and Andrew. While not totally relevant to your day-to-day practice as non-medical prescribers, I do hope you found this interesting, and I do hope that you've learned something new today. I'm really happy to take questions. My email address and some useful links are on the screen, and of course, should you wish for me to send you these slides, I'm happy to do that. Just get in contact. So I'll just hand over back to the chair now, and I'm happy to take any questions. Thank you very much.